Ladies and gentlemen, good afternoon and welcome to the NHS Confederation's conference. My name's Sarah Montague. My job is to guide you through the next few days as chair. Now, has there ever been a time when the problems of the NHS have featured so often in the news as they are at the moment? The focus now seems to be on the crisis in A&E and out-of-hours care, but of course it follows on the heels of the reforms to the NHS and the Francis inquiry into the Mid-Staffordshire scandal and what happened to standards of care. What's clear from speaking to anyone in the NHS, wherever they work, is that there is a recognition of a need to do things differently. But how, and even if that is agreed, how to get to that point. And that is the subject of discussion over the next few days here in Liverpool at this conference. Well, so to get the conversation started and to formally open the conference, can I please welcome on stage, hand over to the chairman of the NHS Confederation, Michael O'Higgins.
Good afternoon, ladies and gentlemen. The agenda in the NHS around providing dignity for patients is dominated by Francis and by finance. And how we respond to these two things presents an immense leadership challenge to the NHS, and particularly to all of you. Now, what style of leadership does that require? Well, in another organisation with which I'm connected, Network Rail, when that took over from the disaster of Railtrack, command and control was needed for a period of time just to get back to an even keel. But command and control leadership only takes you so far. I'm one of those who believes that the right culture is what delivers long-term sustainable change. Bad culture can give real problems. The right culture can lead to organizations that recreate themselves and improve and adjust without needing top-down direction to do so. In the words of the old saying, culture eats process for breakfast. Leadership also requires followership. One of the things that in my business career was really critically clear is if people are leaders, why would somebody follow you? Voluntarily, willingly, enthusiastically. So in terms of the leadership style that's needed to take us through what are going to be some very difficult years, what's going to create the followership that will bring people through while still enabling changes to be made? The best advice I ever had in my business career is that asking for help is a sign of strength, not a sign of weakness. And I think we need to build in that sort of learning culture as we face the challenges that are coming in the next couple of years. And the best quote I've seen about learning comes from Josef Albers, the Bauhaus architect, who said that learning is better than teaching because it is more intense. The more that's been taught, the less can be learned. And for me, that's the difference between hierarchy and network. Hierarchies teach and direct. Networks learn and share and help each other change. And so there are some of the themes that I think we're going to have to be facing as we deal with the challenges of the next few years. And Mike will elaborate more on some of these in a moment. But before introducing Mike, I want to say one other thing. The duty of candor has been much spoken about. We believe in the duty of candor. We intend to apply it perhaps more widely than has been anticipated in the discussion so far. If we're going to make the transformational changes that are going to be needed in the service, we're going to have to help politicians face up to some brave decisions. To do in public what they admit in private. And therefore we'll be using our duty of candor to point out the differences between what they say in public and what they say in private, in order to try to push the debate that bit further along and to support them as they face up to the challenges that are coming ahead. Now, to discuss those challenges in more detail, I'd like to introduce you to somebody who, as the saying goes, needs no introduction. The person who's leading the Confederation with such distinction at the moment, Mike Farrar.
Wow. Well, thank you very much for that, and good afternoon and welcome to the 2013 NHS Confederation Conference. I believe this is the biggest and most important conference in the NHS calendar because it brings together so many of the leaders of all the organisations from across the system. And we come together to discuss, debate, and most importantly, make progress to ensure that the NHS has got a bright and sustainable future. And I make no apologies for talking right up front about the fact that the NHS has got a bright, sustainable future. Very often when you try to expose some of your challenges in order to help people understand the jobs that we need to do, the changes that we need to make, that can be interpreted as people who are doom-mongering, trying to upset the political apple cart, trying to confuse people, in fact, undermine the very service that we love so much. But what I know is that everybody in this room is here this week and does the job they do because they're committed to a bright and sustainable future for the National Health Service. And what I want to talk about this afternoon is how are we going to make sure that when we see these early signs in things like accident emergency pressures, which are warning signs for the system getting into real difficulty, that in being honest and open and discussing those properly, we are seen as being people who believe intensely in the future of the wonderful National Health Service. I also say that because people who've come to our shores recently, like Don Berwick in the wake of Mid-Staffordshire, have said these are very dark days for the National Health Service. They are. But they're really important days for us because it's at this conference and times like this that we find the energy, the optimism, the solutions to some of the problems that befall us. When I just take stock with you about where we've got to, it's very important, I think, to look back at what I was saying last year. This time last year, I had a wonderful quote that said something like, the NHS is a supertanker heading for the rocks, but we do have time to steer a better course. That's what we said last year. It was to try and explain that we needed to change, but there was an opportunity to change. When I think back to that last year, we've had a roller coaster. We all jumped up and down in elation with those giant babies and giant beds that Great Ormond Street provided for the opening ceremony of the Olympics, and that reaffirmed my view that the National Health Service matters so much to this country. But then we fell back down to earth with a shuddering bump when we had to consider the ramifications of Robert Francis's report. On top of that, we've had the biggest upheaval and change in the NHS history, with new organisations coming into fore at a very challenging time and losing many of our most experienced and talented people. But we've also had the chance to introduce new talent into our service with new ideas, and as we go forward, we need to unlock the potential that they bring. We've also seen those financial and demand challenges that I mentioned last year come to the fore, and if anything, be even tougher than they've been previously. And every year we conduct a survey of our members and we ask, what's it feel like out there? And we ask chief executives and chairs of our biggest organisations, and we say, tell us how it's feeling. And there's some really important messages that have come back. We published all the details on Monday of this week, but just let me give you some of the headlines, which is that people are absolutely determined. I think it's something like a fourfold increase in the number of you who are saying the focal point for my organisation this year will be improvements in the quality of care. That's a very positive and obvious response that we highlight in terms of the problems associated with Mid-Staffordshire. But you also point again to this being the most difficult financial year that you face. It's about 25% of you continually say that. I'm always sort of like struck by if it's the same 25% of you who keep thinking this is the most difficult year, you really do have some problems. But I think it's more generalised than that. I think it is more people are saying the financial challenges just simply can't be ignored. And although hearteningly, the number of you who are involved in service change is going up, it's almost half of the NHS organisation reporting they're involved in some form of service change to improve quality and sustainability. Many of you are still sceptical that the conditions that you need to be successful, like the opportunity to get integrated care or the financial flows in the right place, that's not right yet to help you be successful. And so, yet again, here we are saying that the NHS has got major challenges ahead of itself, and we still think the conditions aren't as amenable as they should be for you on the ground to make those changes. And on top of that, of course, we've also seen in recent weeks the problems associated with the urgent care system. Those problems are really important. They're really important because if you look at what's happening in A&E, that is a measure of flow of patients through our system. It's not a measure of hospital performance in its own right, it's a measure of how the system is coping. And if we're facing more emergency admissions that's taking away our capacity to do the planned work, we know the planned work targets, the 18-week target is likely to deteriorate, people waiting for care for longer. And we know that if the elective work is displaced by emergency work, the way in which our finances are structured, it means that more providers will get into financial difficulty. So this is really the wake-up call of all wake-up calls in terms of action. And a couple of weeks back, there was a very important week where there were 3 big announcements made. Secretary of State talked about trying to think about the care of older people outside of hospital. Norman Lamb talked about integrated care, and there was an announcement that NHS England and Monitor would look again at the tariff. Great things and very important things to do. But actually, arguably, the kind of things that 3 years ago people were pointing to say those are the kind of things that we need if we're going to make the financial challenge. And this was a message to successive governments about the need and the case for change. My view is that we weren't listened to then. My view now is that we simply can't be ignored. We want a sustainable National Health Service. We want a bright future for our wonderful service. So what does it take to get that? And these 3 days are important. Now, I have 4 things that I believe are the ingredients for making the changes that we want to make. I'll try and talk a bit more in depth about them, but at headline terms, we need to articulate a strategy which is right for the next decade. We need that strategy to be far-reaching, and we need it to be aligned. When I talk about aligned, I'm talking about them to make sure that all parts of the system are following the same strategy. And that requires the second element, that our business processes, our financial flows and our incentives need to be put together to make sure they are all supporting that strategy. And we also need, something I want to talk about, we need to bottom this idea of how do market-based approaches help the NHS with, with that journey, or where do they hinder them? And how do we shape that in a different way rather than the ambiguity we currently have at the moment? And the third thing is we do need, as Michael was saying, to address the problems of culture in the National Health Service. We need to respond decisively to what came out of Mid-Staffordshire. We need to be able to demonstrate and rebuild public confidence in the way in which we take that change in culture. And that culture needs to be about learning, it needs to be about openness and transparency, and it needs to be about empowerment of staff and the public and patients. And finally, to make all of that work, we need to have a new style of leadership that reflects the way in which the system operates, that's built in the NHS, that's deployed locally, but is clever enough to work collaboratively with the national bodies to create the right framework for us to do the right thing locally. Now, those of you who are fans of care bundles will know that if you get the best outcomes by pursuing care bundles, the 4 or 5 interventions in that bundle all need to be followed. If you do 3 of them, you get some benefit, but you don't get the total benefit. And my view is this, that unless we pursue all of those 4 things, we are simply not going to get the outcomes that we want for the whole of the National Health Service. It's no good just talking about culture, but ignoring the financial reality and the fact that we don't have a strategy that works for us at the moment. It's no good talking about strategy if we don't have the right culture and leadership in place. So I put all of those 4 things together, and I say they're all crucial. So let me talk you through a bit more about what I mean about those 4 areas. The first is strategy. It might feel odd to say, well, we need to have a strategy for the next decade, because for many people, we do have a strategy. That strategy which has been articulated so many times And in fact, today, with the Academy of Royal Medical Colleges and national voices, doctors, clinicians, NHS managers all saying the same thing. We're saying that for a sustainable service, we need to get more money into community, more money into primary social care, and we need to create the right circumstance that we can relieve some of the pressure on our hospitals. And because we only have one pot of money, we're going to have to recycle that money and reinvest it, which will mean taking capacity away from our hospitals. That's the strategy people have talked about. They've talked about more prevention rather than cure, and they've talked about getting the fundamentals right in terms of basic standards of care. But the truth is, when you look at it, we've not been doing that. When you expose the amount of resources that have been going into the hospital sector, and I am not having a go at hospitals here, but when you look at the amount of resources going into the acute sector, much more has been going to that sector than into primary, community and social care. And many of those important aspects for our strategic future have seen a proportionate reduction in resources. So we've been talking about a strategy over here and pursuing another one. And when you look harder, you realise that the last time we had a strategy that we actually followed, it was the 2000 NHS plan. And the 2000 NHS plan was very simple. It said that waiting times are a problem. We need to get that backlog of waiting down. We need to increase capacity in acute care so that we can do more operations to reduce our waiting times. It was a very successful strategy. It was right then. It's wrong now. But we geared our system to do that. We geared the system up to do it. And that's why we have to change our processes. But coming back to my point about strategy, we have a great opportunity with NHS England now to take a lead with local strategies underpinning it to make sure that it's sensitive to local need with CCGs and CSUs and providers at local level working together on that strategy, to re-articulate what we need for the next decade, to set that out bravely and courageously and explain to the public that this is the way to get better services, better outcomes and a sustainable service, and to identify that if we carry on with the status quo, it simply won't work for them. And it's great that we have Health Education England here and Public Health England here who have the opportunity to take some of their decisions about resourcing to get the future workforce or the future investment in health promotion right to support that strategy. We have to look into that distance. We at the Confederation have been doing some work with the World Economic Forum, driven by the fact that the credit ratings agencies are saying to governments, how are you going to get on top of your health spending? Because that's the biggest risk for your economy when we rate you. And they say there are things coming down the line, big data that transforms people's lives by giving them more information about behaviours. The need to transform your health delivery system to maintaining people's health, because armed with more ammunition about their own health, they can be a bigger asset rather than a need in terms of looking after themselves and avoiding resource use until they really need it and keeping that resource use for people when they're really ill. And spending their money with a sense of place rather than the silos of functions so that we align our spending with education, housing, environment, transport, using that opportunity to spend that money more wisely rather than wasting money at the silos. That's what the World Economic Forum says. So NHS England's strategy needs to be far-reaching and embrace that, as well as the new technologies. And our academic health science networks, who again are here this week with us, we need to be talking to them about the acceleration of innovation to support that strategy. But equally, we also need Monitor and CQC, the inspectors, the regulators, the people who govern the financial flows, to be aligned with that strategy, to make it easier for our hospitals to change their business model, to get investment into community services, to make sure that primary care is part of the story rather than in an isolated bubble. And they need to do that, which means that we have to address the fundamental processes that are driving people's behaviours and financial flows. Now, I talked last year about tariff, and I talked last year about risk sharing to try and make sure that you could make progress, even though the system wasn't there properly. And we have made some progress in that respect. I'm very pleased to say I think people are recognising the need to change those things. But I want to just talk about some of these issues that bedevil us when we talk about the market and how market-based approaches affect what we do. And the trouble with this debate, and this is why it's so sensitive, is whenever you talk about the market at political level, it gets hijacked into, is this about privatisation or not privatising the NHS? The truth is that ambiguity about are we using market-based approaches to be successful or are we using planning approach to be successful is actually getting in the way of being able to do things. So boards don't know which way they're facing to make the changes they need to make. Let me give you some examples. The failure regime. Now, at the moment, we're deploying a failure regime that is trying to sort of emulate the way in which organisations fail, and therefore you get service change in other sectors. But other sectors are quite clever about how they do these things. They apply different rules. So when you become bankrupt in another sector, the debt is locked in, and basically at that point your creditors are only going to get so much of the money that you've got. That debt is held until new providers, new suppliers emerge. In the NHS, the minute we declare someone failing, effectively there's probably something like an 18-month gap before a new provider is identified. And what happens in that period of time is that performance deteriorates, often doubling or trebling the debt before a new supplier comes in. So we don't actually have a wherewithal of managing failure in that kind of way. And we need to, if we're going to say service failures are a catalyst for change. The taxpayer is picking up that cost, and that is denuding other services of vital resources in the way in which we're handling that at the moment. We also have failure that organises around institutions when most of our systems operate as systems, and therefore highlighting one institution and trying to solve one problem through that won't do the trick. So we need to think about how we apply some of those approaches to deal with systems rather than single institutions. Let me give you a slightly more off-the-wall example about what we might do. We have a very laissez-faire approach to the way in which our workforce is distributed. And of course, in all workforces, you get the very good, you get the mass of us who are in the middle somewhere, and then you get the poor who are struggling at the other end, the bell-shaped curve. Now, we have a laissez-faire attitude to that, and so people go to where they want to work. And in the main, people don't want to go and work, particularly the medical workforce, isn't necessarily attracted to the failing organisations. It's probably more attracted to the big research teaching centres, and we allow that to happen. And so what happens for those DGHs that are in trouble, or those organisations in trouble, is that they go into a vicious spiral of failure to recruit, and that makes the care even worse. Now, let me give you a very strange analogy, but I think it's worth thinking about. American football. I know you're all aficionados. So American football, the most competitive of sports in the most competitive country in the world, says the teams that finish bottom of our leagues get the first choice of the new talent. They organise their market around labour to make sure that there is competitiveness and equity across their system. Now, I pose that as something to think about, but if we're serious about sorting out some of our problems where we have failing systems, what are we actually doing to deploy our resource to try and tackle that? And shouldn't that be part of the design about the way our processes work? And the last point I'd make about using market analogies and trying to apply them into the health system is the idea money should always follow the patient. We've said that for 10 years. Money should follow the patient. That would be brilliant if we had the right people in the right places and giving the right care at the right time. Yes, we would lock in the financial flows. But the truth is that we don't. So money following where the patient is currently going locks us into effectively a poorer pattern of services than we want. And we need to think about how do we put money in the places where patients can get the best outcomes rather than simply be slavish about saying money follows the patient. And that will challenge the way that we see things. And a great example of that would be, what do we want to do about this 70% arrangement? So we know that it's not working because it might have been introduced at the time to try and do something about the supply-induced demand, but clearly that's not the case. You know, if we return that and say, well, the full amount goes back to the hospital, that's the way to deal with it, money is following the patient, and we're going to lock ourselves in. My view is that that resource, where it's available, should be used to help hospitals, yes, I mean hospitals, not just giving it to the commissioner, hospitals and the commissioner, redesign to take the work away. So we use that money to put it in the right place. And I think if we think about our system in those kind of ways and think about what kind of arrangements we want, there are some opportunities of thinking about markets, but other cases where we don't need to think about markets because it's not helping us. And James Maxwell, I don't know if any of you managed to read, who's the head of the OFT, looking at the referrals that he got. And again there, we can't apply what you do to shoe shops in receivership, thinking about what you do to mergers and acquisitions in the healthcare system. We need something different. Said, and I think this is really profound, is that all markets work on different rules. What you need to do is define the objectives, and then you can get the right rules to apply. And I think what we've done is allow this to happen such that the debate about these market-based systems helping us or hindering us, we've not set the objectives about what we want them to do, so we don't have the right rules. And I think it's really important that we design the way we want competition to be organised in our service, and we should differentiate between the right to supply and who supplies from the approaches we adopt to get change. But at the moment, that's all obfuscated in a big language of is this about privatisation or not. So I'm saying today that what we need to do is help redesign those rules. We need to have our own set of objectives, and then we can make sure that Monitor and our regulators and CQC and our inspectors are aligned to the way in which we need to change the service. Otherwise, we're in difficulty. That brings me to my third area about culture. This is a really difficult area for us because clearly there is absolutely no doubt that we need to change things, but what does it mean? One of the key things is getting the balance right between learning, holding to account, and blaming. This is really, really difficult stuff for us, I think. But if we can't create a learning environment, then as Don Berwick would tell you about the lessons about clinical safety, people do not declare errors and do not feel confident that they can come forward and talk about the problems that they face in order for them to learn and others to learn, then they don't come forward. And if the fear of reprisal is such that we can't allow people to fail, most people learn most when they fail. The risk of us institutionally designing that learning out of the system are great unless we can get the balance right. It's absolutely right, and people should demand accountability for what we do, but we need to make sure that that's fair, and we need to make sure it's honest, and we need to make sure it creates the opportunity to learn. At the time of the Francis report, I rung a number of chief execs up on the second day after Robert Francis reported and said, would you be prepared to come out and say, actually, you know, in our hospital, it's not like some of the portrayal that you're seeing, and we are doing quite well. You know, we're trying really hard. We have some errors, but we're trying really hard. I couldn't get one of them to be prepared to stand up and say, yes, we'll do that. And the reason was because they had a fear that if they said this hospital is doing okay, we're really trying hard to be as safe as we can, that the understanding and the debate in the public at that time about blame for failure would mean that one patient, one family, that the care wasn't right, would become a storm around that individual hospital, and the chief exec or the chair being told they're in denial and they didn't get it. Now, I understand why that happens at those kind of times, but I also understand that if we're going to learn, we have to move on. And I think when you look at the number of chief exec vacancies that we have and our inability to attract good people to those really tough jobs for fear that they are the next one on the chopping block, we've got a real problem in trying to get this balance right. But we must do that. It's vital for us as an industry. It's vital for us as the National Health Service. If we want the bright and sustainable future, we've got to have a learning organisation. The second thing is that we need to have a much more open and transparent culture. Of all the things that came out of the Francis report, the greatest for me was a need to be more transparent. Very often, our inability to connect with people about the challenges we face has been because we've locked our arms around it and said, yeah, we'll try and work it out, and then we'll let you know what the solutions are. Transparency is a great friend to the service. But what it will do immediately is it will expose variation, and we've not told people about that. We know variation because we see the variation between our services. We talk about life expectancy, and it's a moral outrage between 14 years of life expectancy here there. But we've not actually talked to them about hernia replacements and the variation, or hip replacements, or the cardiac surgery rates, or whatever. That's probably the only area that we've managed to do that. So when we start to be more transparent, there is a risk. And the risk will be, this is about bad management again. You could see it coming. But the truth is, it will allow us to explain that this thing about distribution of workforce and this thing about critical mass of care and getting the patient in the right place, whether it's into a specialist centre at one end or away from hospital and care from the community at the other, that will make our case for us. So transparency is great, and I believe that transparency will do more for reconfiguration and improvements of care than maybe years and years of consultation, because it connects people to the agenda that we know and see. When it says NHS above the door, people think you get the same everywhere. You know, and it's not true, and we need to explain why not, and we need to explain why, if we want the same quality everywhere, some of the service changes need to take place. And if we're going to think about honesty and transparency, we should also think about the way in which we connect to people about their own care. We know that when patients are involved in their own care and empowered in their own care, you get better outcomes. And so that journey to help people help us is clearly part of that new culture. And to do that, they need information and they need support. But also our staff need to feel safe and engaged enough to be able to connect to their patients and to use the information and to talk to people about their care. And so we can empower our staff through transparency and openness to help our patients. And if it's good enough to think about engaging people in their own care, then we have to involve citizens in the shape and running of services. And I think it's hugely important that we start to bring people back into our decision-making processes. I was in Tiverton recently. We did a really interesting event about the future of Tiverton Community Hospital. Half the people who were there, it was a scenario planning event. We talked stories, and we had a very open conversation about what you might want for that hospital. We took a futuristic view, and at the end of that, I don't want to preempt what comes out of that, but what was interesting was there was a real appetite in the community to hold the budget for the community services that were provided out of that service, and a real appetite to get a different form of governance around that community hospital. Now, I don't know whether what's going to emerge there, but my bet is that there is a more sustainable future for that community hospital in that community as a consequence of the process to design its future than similar hospitals up and down the country where NHS managers are behind closed doors trying to determine their future. So we have to be confident enough to engage people in the running of our organisations. And non-executives here today, governors who are here today, members who are here today of organisations, there's a massive opportunity to unlock your potential in that new culture. So finally, to come to the style of leadership that we need. I talk about this has to be built in the NHS because the way in which our system operates needs leadership at all levels. It needs to be deployed locally. People's situations and circumstances are different. And it needs to be clever enough to come together where we need it to come together to influence bigger footprint decisions, but also to work with the leaders of our new national bodies. And we need to find a way to connect to that, to inform it and be informed by it in a way which makes things better. So I talked last year about the bravery of local leadership, but from my point of view, what does this mean in practice? Well, where budgets are disconnected, locally we should reconnect them. Where incentives are misaligned, locally we should align them. Where people are talking about the national reputation of the NHS and it's difficult to get into the newspapers about better things, we should talk about the good local things that are happening and the great services. Where we see dishonesty, we should try to be honest and we should support each other in that leadership journey. So a new style of leadership is so important. And one of the reasons why it's so important is because one of the problems potentially coming out of the response to Francis has been an over-reliance, a potential over-reliance on saying inspection and regulation are the answer to quality. They will always be the backstop. They're always about assurance. It's leadership at local level that means that 24/7, 365 days a year, we have the responsibility to make sure that care's right. We have the responsibility to inform the public about change and to take those decisions about transforming our services. So local leadership is so important in order to get the balance right between external assurance and the responsibility of our service to make that bright and sustainable future happen. So my vision would be that we would have a new strategy, and we need to do it fast. And I looked at NHS England to lead that, but to be inclusive in the way that they do it. That it's aligned so that the business processes actually support you in delivering that strategy. It's pursued decisively, and it's intelligently supported by the way in which we're inspected, regulated, and paid. And of course, it is the strategy that rhetorically we've been trying to follow, but now we really do need to. that we would have a culture that was learning and focused on learning, that was honest and open and transparent, and engaged the patients and population in the decisions that we have to make. And that we would have a style of leadership with CCGs locally and local providers, health and wellbeing boards, really feeling able to step up and really make leadership in local systems count in the way in which we talk to the local public about what we need to do. That, I think, is what's needed to try and avoid what we've seen around A&E pressures, that sentinel, that signal indicator of problems, deteriorate much further. We need to get on and do this. The time is running out for us. So what does that mean for the NHS Confederation? What can we do as your organisation, your membership organisation, to help? I said 2 years ago that I would do my best on your behalf to change the organisation, to give to the value that it should, and we are. And I just want to mention a few things. The first is, who is the NHS Confederation now? Well, you've seen today that an alliance with the Academy of Royal Medical Colleges and National Voices, our Commission on Dignity that was done with the Local Government Association and with Age UK, it's about bringing new voices, particularly public voices and clinical voices, to the forefront of leadership of the Trade Association and your representative body. We've just appointed a GP, a practicing GP, who does both in and out of hours in terms of his policy work. He's a Director of Policy, Johnny Marshall. We have Karen Castile, who's been a very, very well-regarded Director of Nursing for many years, coming to work with us to lead some of the work and support the National Nursing Strategy. We have Joan Sadler, who's joining us, who was the National Director for Patients and Public Affairs, coming to work with us. We are reshaping the Confederation to be more relevant and more across the system to reflect those interests. The second thing, and I'm going to pause for a bit because I'm really pleased about this, is that we are bringing money to the NHS. Money that is very, very scarce. And let me just tell you a couple of ways that that's happening. The first, and we announced it this week, is the Equity Fund to support innovations. Working as we have with 14 trusts across the NHS and now adding Northern Ireland, we have been able to bring new resources into the National Health Service, potentially up to, well, tens of millions certainly, and potentially up to 250 million, to back the ideas. We have said for far too long, the NHS invents things, they then have to go abroad, they then develop, manufactured, come back and sold to us at a high price. We need to take responsibility for that. And that fund, available so that all our members can put their ideas in time through into that directory to attract funding, is a way of getting new money into the NHS at a time we most need it. And we'll be doing something similar and announcing something similar about money, probably around 100 million, for energy efficient developments in NHS services around sustainable development. More money in that way. And through membership offers, by being able to organise discounts, if you want to procure a particular service, using the membership leverage to organise discounts, we can also make sure the price of those things, if you do procure them and buy them, are cheaper than they would be. And some of them, well, one of them was worth about £30,000 less than to a trust, which is probably about 4 times their membership fee. So those kind of deals that we can do more of to bring money to the table. We can bring legitimacy to the table. Very, very interesting that Jeremy Hunt asked the NHS Confederation to do the bureaucracy and regulatory burden review. We have no jurisdiction and we don't have the budgets to convert to an electronic system and to reduce that. But we do have the power from underneath to challenge and make sure that those things are done. So bringing legitimacy to the debate is huge. And I think we have to bring something special in the next couple of years to enhance the political debate as people need to talk through and work out their manifestos. We should never again sleepwalk into an election without actually setting out the stall of the NHS and saying to the public, this is what you need to look for in those manifestos. And we'll hope to work with you over the coming months to make sure that when we talk to the public about what to look for from the parties, that we see the right things in those manifestos. And finally, by creating more forums, more opportunities, not duplicating networks and wasting money. Networks have a really solid place. People of the same ilk coming together to look at their particular issues. But bringing forums of people from ambulance trusts, CSUs, clinical commissioning groups, clinical suppliers to the NHS, some of the leadership organisations nationally together into the same place to discuss issues. We're launching an urgent emergency care forum, strongly supported by ambulances, but bringing in lots of people. There will be a social value forum about creating more social value. We are creating forums where you can talk to others in a system where that's harder to do at national level. So 5 things in which the Confed's changes to give you value. I hope at this conference there'll be other ideas that emerge and you will tell us again about what are the things you need. So let me conclude. And I want to conclude with something that I think is really important. And unlike many of the things that I've said today about how other organisations need to go about their business, this is something that we have the capability, all of us, to do. And it's the power in all of us to be optimistic. It's hard to do at times. It's hard to do at times when people talk about the problems that we face. But I come from a world of sport where visualizing success and believing success is 50% of the way to achieving success. If we are not optimistic for the future, then we deserve to fail. I have 4 children. I want them to benefit from the fantastic service that the NHS is providing for me, for my father, for my mother when she was alive. I want them to get that great service. Believing in the future of the health service is the starting point for solving the problems that we face. That belief will carry us through. So I wish you a very hopeful, very optimistic conference. I'm absolutely convinced that the NHS has got a bright and sustainable future. And thank you very much indeed for joining us this week and helping to make that place the place that we all want the NHS to be. Thank you.